carrying on with this point about increasing costs and how that is factored differently from pensions, what do you see the trends in terms of the growth in medical costs over the next 5, 10, and 15 years?
Wow. Boy, that's more difficult to tell right now than probably at any time in my career. And the reason in the short run has to do with healthcare reform. First of all, as we sit here right now, we're not even sure whether healthcare reform is going to survive. Recent court decisions in terms of the constitutionality of aspects of healthcare reform affect it. But what I see in the very short run is I see the insurers trying to take advantage of this lull between 2014, when healthcare reform is going to be fully implemented, and now to try and put through large rate increases. So I think in the short run, we may see higher than normal rate increases because they're trying to pad their profits. Beyond that, it depends on healthcare reform and whether it actually is implemented and how it's implemented. There is the prospect through the reduction in the number of uninsured people to reduce the amount of bad debt that hospitals and other providers have, and perhaps reduce the cost for employer plans. We'll see. But I think it's also important to realize that retiree health valuations, that a very large part of the liability has to do with long-term trend. What is going to happen with the cost of healthcare 15, 20, 30, or even 40 years from now? And there, I'm pretty confident, actually more confident than the short run, that the large increases that we've seen are going to have to come down and moderate some. Why? Well, because as the cost of healthcare outstrips inflation, healthcare takes up a bigger and bigger part of the economy. As healthcare takes up a bigger and bigger part of the economy, the U.S. economy loses jobs, both manufacturing and service jobs, to other countries. The number of uninsured grows, and politically and economically, that can't be sustained. So over the very long run, I think it's not possible for healthcare costs to increase any more than inflation plus economic growth, maybe 1%, maybe 2% at the most, more than the inflation rate.
And for the next 5 years, you would think it would be inflation plus, CPI plus?
I think there's a difference between Medicare and non-Medicare. The cost of healthcare for non-Medicare has been increasing at a rate of about 5% more than inflation. I think it'll moderate a little, somewhat, maybe to 3 or 4% above for the next few years, but it'll continue to be significantly above the inflation rate. For Medicare supplement policies, costs have pretty much increased along with inflation, not much faster. So there, I think you're looking at maybe 1% over inflation for Medicare costs.
In terms of the folks here that are listening to you, they're concerned about sitting down and negotiating, and they want to know what will have the biggest impact on the actuarially required contribution or the annual contribution toward OPEB benefits that they have facing them when they get back. From your perspective, what 3 or 4 things would you prioritize in terms of having the greatest impact on that arc?
Oh, wow. Of course, first of all, I need to say from the outset that as an actuary, we're not really, we don't really advocate any particular benefit program or benefit plan design. Our role is simply to value the design that's been agreed to by the parties. But there are several points that I can make. The first one is that one of the biggest ways or the most effective ways to bring down the arc is to fully pre-fund the benefit. Fully pre-funding the benefit means you have to have the cash to do that. If you fully pre-fund the benefit, you're allowed under California government code to invest the money in a wide array of investments that generate much higher long-term returns. As an actuary, I can give you advance credit for that investment income and that will reduce the amount that you have to take out of your budget to pay for the benefit. Now, if cash is a constraint in the short run, that's not necessarily going to help you very much. So there you're really talking about changing the benefit design itself. It's important to consider that whenever you save money by changing the benefit design, you're only going to save money if you reduce the number of people you're paying for or you reduce the amount that you're paying for people. Now, there are ways to do that without affecting the benefit very much. One way, for example, is to establish a cap on what you pay. It's very common to establish a cap based on a benchmark plan, maybe the lowest cost HMO plan, for example. That's something I've seen very commonly done. That still allows people to have their benefit paid for, but it restricts choice. But that can be a very effective way to reduce the cost of benefit. Another way that you can reduce benefits is by introducing the idea, if it doesn't exist, of a retiree contribution. When you introduce a retiree contribution, it saves money in two ways. First of all, you have a direct savings based on the reduction in cost of the contribution itself. But what you'll find is, even for a relatively small contribution, there's some retirees who have dual coverage. They may have coverage through a spouse's plan. They may have coverage available through a military plan. And if they are required to pay even a little bit for their coverage, they may choose not to take the coverage and have the alternate dual coverage instead. That saves the employer the cost of the entire coverage.
What about going to a defined contribution plan?
That's something that's increasingly being looked at. It reduces the ARC to the extent that the contributions made by the employer to the defined contribution plan are less than the ARC currently. Defined contribution plans have been used in the private sector quite a bit. I'm seeing increasing activity in the public sector, and that's certainly something that could be viable, particularly for relatively young employees. They can accumulate a fairly large account balance that can provide a very substantial benefit in retirement. And the advantage, as you say, is that the liabilities equal the asset. The benefit is defined based on your account balance, and there is no liability beyond that.
So in effect, there's no liability, there's a zero ARC.
Yeah, that's right. Once the employer pays whatever their required contribution is, essentially their obligation is completed.
Jeff, I know you've been around a lot of the negotiations on OPEB, and you've observed employers engaged in that activity. What general advice, 3 or 4 major points, would you like to emphasize for employers when they sit down to negotiate from the perspective of an actuary?
I would say the first thing would be, kind of looking out the window, is that a recognition that the portion I deal with as an actuary is only one component of the total compensation piece. That the availability of a health benefit is going to change the retiree's decision about when they retire, which is in turn going to have an impact on the amount of money paid out in salaries. So it's important to keep all that in mind in looking at this issue. Before I talk about a second point, I want to emphasize that one of the things that doesn't happen enough but is really important is to keep the actuary in the loop when you're discussing potential plan changes. There have been a lot of times when I've been called in, I've been told that there's been a change negotiated in the plan, and the people are amazed that it doesn't have as much of an impact as it does. They think it's going to have a bigger impact. Involving your actuary when you're first starting to brainstorm about plan changes is going to avoid a lot of disappointment and a lot of misunderstanding. The third thing I would say is that getting back to the point earlier about health benefits having been established for retirees back when it was a fringe benefit, I think the benefits would be designed a lot more differently based on today's cost realities. Sometimes it's important to take a step back and say, how would we prioritize the benefit between employee dependent, medical, dental, vision, Medicare, non-Medicare benefit if we were looking at this fresh today? How much can we afford to spend on this, or how much can we agree to spend on this? And then look at what the program would look like if you were designing it fresh today. If you were to do that, you'd find the benefit design might be a lot different, And that may suggest that you might want to evolve to something like that. Might look more like a defined contribution plan, for example. So I think it's important to look at things fresh and try and shed the historical kind of view of the structure of this benefit and think about it in a new way.
Jeff, on behalf of CalPELRA and all of our trainees, we want to thank you for being part of our training, and we hope to see you frequently throughout the state in all of our endeavors to try to deal with this very difficult problem.
Thank you. It was my pleasure.